great ideas about prevention and what can be done in the world. She's intelligent, she's beautiful, and she's gazing rather wistfully at this older boy there. And for me, this older boy is treatment, and he's gazing out, not at her, but he's looking, you know, down there, and he's seeing the human genome and personalized medicine and big data and, you know, everything bright and shiny, and he's completely ignoring prevention. But, you know, she's going to keep looking at him, and she's eventually going to stand up and she's going to go over to him and she's going to say, here I am, we're going to do something together. It's not all about you. Next slide, please. So, do I move this on, or sorry? Great, okay. Is that working? No? Other side? Where? Which way? sorry, where do I go? It's not. Ah, brilliant, yes, good. Yeah, no, okay, good. So, first of all, we had some discussions in the group about what prevention is, because we talk a lot about prevention. But what became very clear in the group is that prevention it takes very many forms. And prevention is getting broader as a concept every day that we talk about it or don't talk about it. So it's vaccination, which not only prevents lots of diseases in and of itself, but it also helps in the fight against antimicrobial resistance, because if you get certain types of diseases that vaccination could prevent, then you have to give antibiotics, and that just increases the threat of AMR. It's smoke-free places, it's taxes and marketing restrictions on harmful tobacco, foods, beverages, polluting industries even. It's warning labels on products, it's low emission zones in cities, it's free or subsidised public transport, it's better housing, it's employment and a decent level of income, and it's also coming back to the more micro level, it's things like good screening programmes. And I was really struck yesterday by what Mark Pearson was saying about the role of employment and income, and your parents' employment and income, and the role of social mobility in health. Because I personally come from that background. My mother was that child in that 10% born just before the war, and she kind of got out of that group, and now I'm her child, and here I am standing in front of you. So for me, the social mobility argument really spoke volumes, as I think it probably does for lots of people of my generation. And I do remember holding the first group of the Friends of the Liver group in the European Parliament a few years ago, when we were talking about liver health and the importance of alcohol control and all of these other issues. And at the end of it, one of the MEPs sitting on the group said, you know, yeah, all of that is true, but where I come from, which was the northeast of England, he said, really, the best way and the best route to good health is for someone to have a decent job with job security and to live in decent housing and know that they've got decent education for their children and they can provide for their families. And I think we probably don't pay enough attention to that as a public health community, and we should, and I'll definitely come back to that in a minute. Right. So why have we been slow, and I say not we as a public health community, but society, why have we been slow to adopt proven prevention measures? I mean, I think there's a lot of reasons for this. But first of all, you know, one thing to point out is we're always told by politicians and policymakers we need more data. And frankly, we don't need more data to do what needs doing. We have enough data. Maybe not in some of the new areas like digital, but you know, in the traditional areas, we've got plenty of data. Yes, we're told we need more economic data. No, you don't. We've got enough economic data. Just act on the data that we've got and let's see how far we get. So that was a very clear message. It's always good to have more data, but let's not let we need more data be the argument that puts us off. What we don't have is political will for most things. And there are some very good reasons for that. And one of those is, you know, the commercial, what we call the commercial determinants of health. Because we have not been able to make the arguments or get our arguments across to cut through what big industry is doing, you know, big fossil fuel, big tobacco, big alcohol, big food. They are a constant block to what we want to do. Sometimes we have successes, and tobacco control is a good example of that, but those successes are always in danger, as we see now with the rollback of, tobacco control in places like Turkey, where we thought that battle was won, and, and now, Boris Johnson, who might be the next Prime Minister of England, threatening to roll back smoke-free in the UK, for example. No, battles that we thought we'd won are still under threat. And we have to do something about these commercial determinants of health. And allied to that, there's a lack of public support. When you ask people, yes, they support these things, but will they come out and really, really support them? We don't know. Maybe if Boris Johnson does roll back the smoke-free workplace law in the UK, maybe people will go out on the street. Who knows? I doubt it very much, but we'll see. I think also as a public health community, we haven't got our messaging right, and this is particularly true on things like vaccination. We go out and say, but the evidence, the data, again, the evidence and the data, but that's not cutting through. So we have to find more ways ourselves to get the messages right, and we have to find out and understand why people are not responding as we would wish them to, or politicians are not. And perhaps as a public health community, we could be more activist and maybe a little bit more radical. I was very lucky to be able to step out of the Brussels bubble in between 2007 and 2012, and I worked on a global health level, and I worked with some fantastic advocates from Latin America, from Africa, from Asia, and they are really activists. They will go out and they will make the case, and they will fight the most horrific governments in some cases, but they are activist and they are radical, and they appreciate that they have a role on the front line of society, really. They have an activist role that they have to play, and that health in lots of countries, including here in the EU now, is on the front line of some very, very big societal debates and challenges and trends that, if we don't stop them or slow them down, are going to really impact on health. So what do we do about all of this? What came out clearly from the workshop yesterday was that education is key. We have to do much more around education, starting at primary level, and it has to be lifelong learning, and we have to engage with our communities, with our members. And again, messaging and getting the right messages comes back into that. Health is all about trust, and trust in society is at a really low level right now. This is why we have the vaccination crisis, because parents and even adults do not trust governments, and they don't trust scientists, and they don't trust doctors to give them messages about vaccination. So we have to rebuild trust. Trust is the key to getting prevention, and it's also the key to a whole lot of other things about what we want to see in society, and just getting to that vision of a healthy Europe for all. And as part of this, there was one table that focused very much on one issue, and that issue was austerity, which is, was lots of governments now across the EU are embracing policies of austerity, and that was built on a lie about why the 2008 economic crash happened in the first place. But health is very often, and especially public health, is very often the first victim of austerity. It's the first policy that goes, because we need to fund other things. We need to fund education. We need to fund highways. We need to fund public transport. And it will go. And also, we also need to fund all of those tax cuts for billionaires. So I think for us going forward as the public health community in the next 5 years, we have to take on austerity. If we don't, everything that we hold dear and all that we have achieved so far is at risk. And again, trust comes back into this. For an effective vaccination program, you need herd immunity, so you need 95%. If you don't, you can tell people to get vaccinated, but if you don't, if there's shortages of vaccinations and if there's no money to pay for vaccinations, then, where are you? You don't have public health again. So we have to really get to grips with this discontent. And I would finish by saying health and prevention are being weaponized by the far right to build their own political base and to form governments. And we have to accept that. We cannot just step back and say, well, I just work on alcohol control, or I just work on this. We have to see ourselves as part of a much, much bigger picture, and we have to go out and engage with organisations and civil society who are working on these other issues. And maybe, I know some of us already are, but we have to really step that up and really take on austerity. Because at the end of the day, you know, if we continue with this, as Mark Pearson said, we're just going to end up with more and more ill health. So coming back to what we can do in the next 5 years, in the elections, we were promised a lot by the politicians, you know, but more transparency and better governance and upholding of the rule of law were key promises by almost all the different political parties. And when the new commission comes in and the new parliament, we have to really hold their feet to the fire on all of these issues, because we need transparency in lobbying and advocacy. We need to put a brake on commercial interests who are not lobbying in our interests. So I think there's a lot that we can do in the next 5 years. Having health located as part of the social pillar will, or should be, if we do it right, and you heard a lot about that yesterday morning, that should help us to really, really make some progress on this. And I think ultimately we have a goal, it's in sight. Let's hang on to what we've got, but let's not settle for hanging on to what we've got, because that will be the big issue for the next 5 years. Let's just be bold and ambitious, and let's use every single instrument that we can, and let's recognise our place in the bigger picture as a public health community, and let's go out and do that for public health. Thank you.
Super, thank you very much, Fiona. Please stay there, because I think there might be quite a few comments, a lot to think about there. The idea of the health community being less complacent and more activist came up. The importance of trust, fundamental. Austerity, actually tackling austerity as a core issue. The absence of political will, and not always seeking somehow recourse in the need for more research, more data in order to actually act, because that creates too much inertia. Okay, everybody, lots to think about. The people who were in Fiona's group, any additional comments, insights, thoughts? Please.
I am Tuna Kotai from Hungary. Yesterday I was taking part of the austerity group, and we found finally that what's missing, the clear vision of the governments, the national governments, what they can do and what they have to do for the health of the nation, of their country. I think that we have to repeat here also that we need a clear vision and mission of the national governments.
Okay, well, in that case, since we have a couple of representatives here, perhaps you'd like to comment on that?
As I said yesterday, I'm a big globalist and pro-European and Europhile, and I would very much like to see what I mentioned yesterday was Ursula Care, a more unified, equalized healthcare system across the board in Europe. Okay, Europe is too federalized. It's too fragmented. It's too much broken up into little kingdoms. You know, I think Garibaldi is rolling in his grave, and Bismarck, etc. So it's a question of moving towards a more unified union of states, and in healthcare and education is one of the biggest benefits that the people can see in a very short term. As it was mentioned yesterday, we all saw the benefits of the roaming unification in Europe, and I think in the questions of education and the questions of healthcare, this is something that people can see the benefits of very, very quickly, especially when you compare Europe with the haves and have-nots, or the north, south, east, west things that we're dealing with. I think something that I continually talk about in Croatia is that we have, according to our demographics and our statistics, we have 7,000 preventable deaths per year in cancer alone, just in cancer. Why are these people dying is because the lack of linear accelerators and the lack of access to innovative medicines. Countries in Europe, very many countries in Europe, have access to this. Our country does not, okay? Is it somebody's fault? It's not a fault. Is there a system in Europe that can be put in place to equalize your equal chance of surviving certain diseases? Yes, I think it is, and it's not very expensive. It's mostly an organizational question, not a financial one. But when we're all stuck in our little kingdoms, our little Westeros, and fighting between one kingdom and another kingdom and who's going to rule Westeros, and we're all going to be stuck where we are today. And I commend what was said about political will. Whenever I go to any country, it all comes down to the political will of whether or not reforms are going to be done. And a lot of times, very many people don't realize the bitter pill that has to be swollen at that certain time to be able to have reforms that bring about betterment to everybody later on in life. Thank you.
Yes, thank you for a good wrap up. And what I understood, you really had a good conversation and discussion yesterday about this. And I really liked the first picture where you had that little girl and boy there, both of them like seeing to the future and wondering what beautiful there will be for, and all the potential they can have living in Europe. I would say that we have had during the previous parliamentary period, we have had a good opportunity actually, and I was very positive of how countries really are interested in having a dialogue and discussing and agreeing on that social pillar is very important. We first all thought that, okay, that is something that politicians only take up, or Juncker only take up in the beginning of the Commission period then. But it really flies again. When we had now our first discussion, the ministers were discussing then last Monday on the economic of well-being. Then the social pillar came up from each country's interventions. So there is really an understanding and positive thinking towards these things being a part of also semester process. And if we think about the treaty, then the semester process actually includes everything that each sector. And that is something we should build then on. And lastly, I would like to say that also we should probably strategically concentrate and focus more on the cost of ill health, and understanding that in these austerity discussions and attendance to say that if we do nothing, if countries do nothing, or even less than now, it will really cost a lot. So there is not a zero possibility that if we do nothing, nothing happens and the costs won't then rise. Yes, we should, like the cost of ill health, take that more, and take then the financial organizations with us. Showing what that is, measures there and indicators. So OECD would be a very good partner.
Martin, very briefly, comment from Germany.
Yes, just one comment. I completely agree with everything that was said, but I want to add that the discussions concerning prevention is often connected to the idea of punishing patients. And it's very easy to say we've got to punish smokers, we've got to punish those who don't go to dentists constantly. And this is very easy for the government because it doesn't cost anything. It's a cheap measure, because then you can say those people who are punished, they don't get their treatment reimbursed. And therefore it's very important to focus on information, on development of health literacy and these measures, and to take care that on the European level these ideas of punishing patients are not in the role that we have, for example, in Germany.
Very important point, Martin. Any other comments from the floor here? Actually, it's Karen who came first.
No, you can go first.
Yeah, stand
It's
first.
fine. Oh, Stanimir, go.
Oh, okay.
All right.
Fiona, I just wanted to take you up on the words of activism, and I think you're right. It's really so important to go out and be active and promote what we need. In that, it's so important also, as you mentioned, to make alliances. And I've been, a few years ago, I started the Biomedical Alliance, which brought together scientists, healthcare professionals across different fields, which was not easy. You manage that also for the patients. You have a European Patient Forum. You have different stakeholders that have made their own big groups, but now we have to come together. And we have to work together, and the object, the subject, and the task is health for people. And health is a key word. And I think you are in a very good position to build on these alliances with what you are doing here today.
So, very briefly, maybe one sentence response to what we've heard from the crowd.
Yeah, thank you. Yes, absolutely, Karen. I mean, as you know, I come from a medical society background, so very, very keen wish of mine to see the medical societies engage with us and vice versa. I don't have anything to disagree with. Just on the education point, we did talk a lot about that, and also about language and the need to move away and not talk about things like sin taxes, but health taxes, for example, and not to make the individual feel as if it's their fault when, you know, the fault lies elsewhere. So, yeah.
Great. Thank you very much, Fiona. I think also the idea of prevention and patient-centred chronic disease management being part of one continuum rather than being somehow in conflict or contradictory is really important as well. Let's move to our second workshop, which is really looking at the 5 A's: available, adequate, affordable, appropriate and accessible healthcare, with a good dollop of equity thrown in there as well, and that came up in the workshop. This workshop was actually organised or co-organised by DG Santé. The moderator was Nikos Dedis from the European AIDS Treatment Group, and the rapporteur is Usman Khan, Executive Director of the European Patients Forum. Usman, the floor is yours.
Thanks, Nicola, and good morning, everyone. It's a nice position to be in, other than misspelling session. It's a nice position to be in, to be able to reflect overnight on what I found to be very interesting session, because it was, not least because it was a double session. So we just to be able to see what levels of continuity there were over the two groups and what potential differences there were. I'll go through just a little bit in terms of summary, but I think my overriding sense of it was really encapsulated with three words, and maybe we can sort of see how we go through these in the slides. The first one, I have to say, I'd say was frustration. And we'll talk about that, and that related a little bit with Kaiser in the presentation from Santé in terms of the evidence base. And I'm very interested, in Fiona, in your point on that, and I've heard that, you know, we've got it, let's just act on it. But there was a response on that. I think the second word that came to mind is humility amongst all stakeholders in terms of reflecting on where we're at. And then, thankfully, I think the third one was really resilience. And we are at a point, this is the end of term, isn't it? We're all going to go away for the summer, and then we're coming back for our next year at college with the new commission. And I have to say that if I'd been asked 6 months ago or 9 months ago, how are we feeling about next year, and we being health, I'm not sure that there would have been as positive a feeling as I think there is now. I think we're feeling there's just that little bit, we feel that we can have hope, and that the next 4 years could provide a basis to move forward in the way that we weren't necessarily feeling even a few months ago. So now I need to see if I can make the pen work, the magic pen work. And then you can see that I've failed as well. Yeah.
The other way around.
we've all, as rapporteurs, we've now had training courses, so at least as one output from the last 2 days, we know how to, and but you'll have to see how you do with point and shoot on this. So what I wanted to do, actually I wanted to go back. That's going to be even more dangerous, isn't it, if I try and go back. Yeah, so just to be able to say, I won't go through the 5 A's again or test anyone on what the 5 A's were. Just to be able to say we linked those 5 A's with 3 questions, and then we had 2 presentations from Kaiser from DG Sante and then from Micah from the European Public Health Association. But basically what the session was focusing in on was delivering health system sustainability. That very much, the group very much sort of coalesced around that as an objective quite quickly. It is. This is like this is trying to do this. I was watching people fail. I think it can't be that difficult. Just press the button, and then when you actually get to do it, yeah, no, it is that difficult. We will stay on this. So the way that I've just tried to sort of structure it is people will know where are we now, where do we want to be, how are we going to get there, because it did sort of naturally fall into being able to assess baseline where we are. Oh no, I've gone back to the start again. Being able to, there we are, being able to, from the presentation from Kaiser, from DG Sante, and it was interesting, a lot of people were clicking up and doing their camera photos, and what that was saying to me was that people hadn't necessarily seen this evidence, or they hadn't seen this data and they hadn't seen it in this way. But I think if I had to sum up the debate, there are a lot of questions that came from it, is that we're moving from a position of invisible to opaque, that we are now beginning to get evidence. Whether that evidence was always there, but we didn't see it, I don't know. But it's still opaque, and there's still questions about it, and I don't get a sense that there's confidence in it amongst the stakeholders. We were there. There was an appetite for it, but I didn't get a sense that there was necessarily confidence in it. Healthcare, we are absolutely awful at patting ourselves on the back. We really feel guilty about the notion of being able to say, job well done. But we did give ourselves a little pat on the back because we could see the graphs in terms of being able to see health outcomes. If you look at what we're able to do in terms of life expectancy, if you can look at what we've been able to do in terms of well-being, we have improved. We can't deny it. But what we were discussing yesterday was the fact that we're now beginning to potentially flatline. If we don't start doing things differently, we're potentially flatlining. Access was really the elephant in the room. And I thought that the case study that Mike brought up about the unavailability of any treatments for multiple sclerosis in Serbia. How can we call ourselves, how can we talk about European health systems if we have these huge gaps? We really have to be careful about trying to do it. But we should always use those as reference points to be able to say, okay, how can we measure whether we're making progress? I think the other thing is there was a lot of discussion about whether it was about integrated care, about care pathways, about to be able to say, why are we not doing this? We've seen what good looks like in one area. Why are we not doing it in consistently across the board, setting aside issues of resourcing? And I think what we did understand was that the obvious is not necessarily the easy. There's a lot of blockages, micro blockages that stop you, aside from resourcing, being able to get from what looks like effective practice to consistent practice. And then we did, as a group, conclude that the status quo is not an option, and we had some statistics to be able to show you know, what the GDP spend on healthcare. I think we're looking at Croatia and the United States of basically Croatia would get to the point where the United States is now, and the United States would get to 80% of GDP spend by 2050. If it continues, if we just allow health systems to develop and respond to demand in the way that they have done in the past. Look at that, getting a hang. The second one was, although have I gone too many slides? Where do we want to be? So on where do we want to be, the simple one, and it may sound very obvious, but it was well made by the group, is we want to be in a place where we're using resources efficiently and where it adds value. And that goes back to evaluation, it goes back to data, it goes back to management, it goes back to research. But it's that part to be able to say, are we really getting the bangs for bucks that we should do or we could do? And I think that's the sort of benchmark of where we want to be. It was also raised within the group, it's the money stupid. You can't ignore the fact that some health systems, if you have less developed countries spending less of their GDP on healthcare, you cannot expect them to suddenly match health outcomes in more developed countries that are spending a larger percentage of their GDP. It's not simple magic. So you can't ignore money. This issue, we were talking about whether the 5 A's needed an E on the end, and I thought that was interesting. Did it need something about equity? But what the point was made within the group is that access does mean equity, and I think we need to keep reminding ourselves that we know that there's a risk in terms of exacerbating health inequalities, and that we must be watchful of that. Then linking on with Fiona, obviously, in terms of adding another A to the 5 A's, in terms of avoid. And I think that a really strong, powerful example in terms of, I think it's just 3 countries, if I remember right, including the Netherlands, who are doing effective colorectal scanning on a condition that if you don't do it, you are nearly always going to diagnose it through physical symptoms too late to be able to do anything. And that's about well-being, that's about death, and that's also about increased costs to the health system. And the same thing about, well, how do we get from 3 to 28? What are the challenges? And we know it's not just about resources. We know there are a whole host of other challenges involved in that. And where do we want to be? It was also, I felt, in terms of the ambition that this is about people-powered healthcare. And yes, maybe I'll say that in terms of my role at EPF. But there was a general sense that this needs to be something fundamentally different. It's not just about the patient and the public being added on to the existing healthcare system. It's about something much more transformational. So then finally, how do we get there? And as I say, apologies to the group, it'd be great if you can add your own points in. These were just some points I picked out. It certainly came out, let's build on small is beautiful. We know that there's some really effective work happening in smaller countries, not necessarily most developed countries, and also regionally. And to be able to connect with the regions in a more meaningful way, and also connecting with civil society and making the best benefit of civil society. And the idea of having multi-stakeholder platforms, we have that here. I mean, that's what PACT is being able to do. But we need to recognize that we need to connect more. And if we can do that at a national level, if we can do it at a regional level, local level, then we can get increasing benefits from it. Second one is that healthcare needs to get out more. We're quite an introverted world. We like to talk to each other and sort of grumble and complain and sometimes kick the can down the road. This is the time now where we need to be able to make fundamental alliances with environment, with social care, and that's where you can see it and you can sense it in the new parliament, I have to say. And if we don't hear and don't take and follow that lead we're being given, then I think the cause of improved healthcare could suffer as a result. The group were supporting PACT in terms of their support for SDGs, remaining credible, but saying that they should be an anchor point, and then it's about building evidence, building research, building that systems around them. A little bit of a discussion in terms of technology, and I thought the point that I drew out from that is about getting best value from technology as an enabler as well as being a direct problem solver. So being able to connect technology rather than thinking of it as something distinct. And equally, finance should be an enabler and not just a solution. So I think that's, that was where we were able to get. And I think before I stop, the last thing I'd say is one of my sort of reflections. I was keeping quiet, and also thank you very much for Kaiser for taking additional notes, my colleague from EPF, to help me write these notes up. But I do feel that getting out more, when we were saying we need to be more efficient, we need to use resources, we are not the most inefficient sector. Look at fashion, look at transport, look at construction. We need to reference, because I think if we reference more, if we look out more, we ourselves can actually get some confidence from some of the good things we do, as well as learning effective practice from some of the areas where we'll be able to do that. So that would be my last point, Nicola.
Lovely. Thank you very much, Usman. Thank you. So stay there, please, because we're going to have hopefully some points from both the panel and indeed the audience. Frustration, humility, but resilience, ultimately. Any comments from the group that was with Usman yesterday afternoon? Any clarifications, please? Can you keep it rather brief?
Oh, yes, I'll do that.
Great.
Usman, thank you very much. By the way, my name is Maika from the European Public Health Association. Thank you. I think that was a really good wrap-up of our session. So not too much to add, but more to complement. So we talked about the health systems, and you ended now the sum up with that we have to take action. And I would like to add to that, we have to ask ourselves more often, what if we don't take action? What are the costs of inaction? And I think this applies also to what Fiona was mentioning. What if we don't make sure that the girl gets up and walks over to the boy? What if there's no action in our preventive work?
Thank you. Really key point. Any other comments? Anything from our esteemed panel? SDG Watch, anything on the idea that the SDGs remain credible as an anchor point and building an evidence base around them?
Yes, I completely agree, and I think we wouldn't find anyone who would disagree that SDGs should be the guiding framework for the EU, for member states, for every country in the world, because it's an international framework that everyone committed to. As I mentioned yesterday, EU has published its implementation package in 2016, which laid the legal basis for EU to take SDGs as a legal framework for its different policies in different areas. And unfortunately, what we see for now, as it was mentioned yesterday, EU is not being ambitious enough to put concrete targets, timelines that would help to achieve SDG targets. There are many EU agencies that constantly say that we are not on track to achieve SDG targets related to health, so EU needs to do more. And our role should be to keep EU accountable, as this is what SDG Watch and our Alliance members are doing, to keep EU members and EU accountable for its commitment that it has taken in terms of implementation of the SDGs.
Thank you, and I'm sure we'll hear a little more about that further down in today's session. Pavi, you wanted to come in, no? Sukin, please, go ahead.
Okay, thanks. Something that wasn't mentioned yesterday, but I think the intersectoral cooperation and comparison with everything else. For instance, when we were doing the master plan of hospitals in Croatia and reducing the number of communist times defined hospitals, which isn't actually true, because they were defined even before, during the time when transport mode in Croatia was horse and buggy. So it said, by horse and buggy, how long does it take you to get to a hospital? That's just how many hospitals we need in Croatia. In the meantime, we have brand new highways and transport and still have the same number of hospitals. So the overabundance of infrastructure causes inefficiency in the health system. So when they ask me how would I reduce the number of hospitals, for instance, Western Slavonia has 8 hospitals and a catchment area of 150,000 people, which is ridiculous. So I said, very simple, build a highway between Banja Luka and Načkanije. Okay, so if just geographically you build a highway between, a straight line between these 8 hospitals and reduce it to 1 hospital. So it's intersectoral cooperation, transport, communication. You build the highways, we will then do our efficiency because we have the new infrastructure. And then we have horror stories. For instance, to meet the SDGs and what we have through the WHO, for instance, reduction of salt intake, sodium intake in our daily diet, reduced to 5 grams a day. Okay, every single member country that's sitting here has this signed by 2030 that will reduce to 5 grams a day. So we have a bylaw in Croatia that is in accordance to EU law that regulates the ingredients of bread. Okay, and it says how much salt is allowed to be in bread. So we wanted from the Ministry of Health to reduce the salt in bread. Me personally, as Minister of Health, talking to the bureaucrats at the Ministry of Agriculture, 25 meetings through 1 year. Okay? I almost took my shoe off like Khrushchev and started to bang on the table for them to reduce the salt in the goddamn. And what happened when they finally did it? Nothing. Nobody even noticed in bread that there's change in taste or anything. Nobody noticed. Okay? But just so you know, economically, in Croatia, 2 millimeters of mercury in the blood pressure gauge, 2 millimeters equals 80 million euro savings in cardio medicines. Okay, so just the savings through this is irreplaceable, and not even talking about the lives. And just my final message. I think we have some people here from Holland. And also from Switzerland. These are 2 countries that in Europe have legalized euthanasia. And Belgium also. However, this is voluntary. What is the opposite of euthanasia is murder, okay? So if Croatia has the chance to save 7,000 lives by investing in linear accelerators and in life-saving cancer medicines, okay? And somebody says by conscious thought, even though we have a surplus in the national budget, we will give this surplus to defense, payment of international debt, everything, but we will not give it to health. This is conscious euthanasia or conscious murder of 7,000 people. And when we're talking about being more active and more impactful with our messages that we're giving, I say this is maybe politically incorrect. Okay, talking about murder and euthanasia, but when you come down to it, health systems make sure that people stay alive instead of being dead, make sure that people are healthy and not being sick. So if it's binary like that, then being alive and dead is something that is our job, and anybody who's hindering this job, in my opinion, is a murderer. Thank you.
Wow. Okay. Thank you for
Really
that,
good
Sinse.
example on economy of well-being, and the reason we should have these health and prevention, especially prevention, discussed in finance ministers' table and around semester. So European semester is there, and financial and European Commission is there for making sure that we have sustainability in economy. Isn't that what we just heard? A very powerful thing, influencing on sustainable economy.
Absolutely, absolutely. Thank you. I'd like to give the floor very briefly back to Usman to try and make sense of the very rich comments that we've just had in the context of what you were hearing yesterday.
No, I will do. Very briefly, Nicola, I think I'm just going to connect as a final call. I think I have to say I don't finish work for another month, but I am thinking about the beach at Puglia already. I'm sure you're already doing that. What I would just say is a sort of call to action, that when you think of your first meeting that you're going to hold when you're back from your holidays in September, make it be with one of the people with murder in their mind. Talk to someone from outside of the health world, because we need to do that if we're going to be able to make progress. And I think it would be a very good marker to be able to start the year in a positive way.
Super, thank you very much, Usman. So moving on to workshop number 3, looking at workforce challenges but also opportunities. And this was co-organised by CPME, representing the doctors, physicians community, but obviously it wasn't purely looking at doctors' challenges, but really looking at the healthcare workforce much more generally. The moderator was Sarada Das, and our rapporteur is Annabel Seebohm, the Secretary General of CPME. Please, the floor is yours. Tell us about your discussions yesterday and some of the bold moves taking that forward.
Thank you very much, Nicola. First of all, I need to know how this works. Which button is the
expert?
Lena, is it the top button?
Yeah, you have to hand to the sign.
This, okay, very good. And also, I would like to thank Stanimir and Lena very much for organizing this event. It's, as always, very fruitful and very nice being with you and discussing with you. So thank you very much, Stanimir and Lena. Thank you. Yes, we had a workshop yesterday, and we had a keynote speaker. His name is Bojan Popovic from the European Federation of Salaried Doctors, FEMS. Basically, it's a federation of trade union doctors. And he's a very knowledgeable doctor and lawyer with a special interest in workforce conditions, workforce migration, and collecting data and drawing conclusions from that. So he gave us an insight in what he found on the topic of shortages and uneven distribution. So he just focused on one challenge, really. And he did this on the example of doctors, but he told us what he found out is also transferable, in particular to nurses. So numbers very much are in line with what he found for doctors. He also mentioned that he couldn't really find good data on other professions simply since they're not available or non-conclusive. So we took his presentation as a kickoff to further dig into it. Now, as to the challenges, I mentioned he presented shortages and uneven distributions, and he drew attention to the fact that there are medical deserts in the European Union. There are regions where you don't have access at all to professions, or you have to travel for long distances. He spoke about also particular lack of certain specialties, in particular on GPs and family medicine, but also pediatricians, and pathologists, which is in fact crucial because otherwise you can't do surgery if you don't have a pathologist around in certain cases. So he really gave us a full picture of special problems, and he presented data provided by the OECD, but these data showed paradoxes. For example, there was no correlation between the salaries and density. So higher salary doesn't necessarily mean that you have a higher density. So, for example, you have a high density of doctors in Greece, apparently, but the salary is not necessarily high. You'd have no correlation between life expectancy and ratio of doctors. Well, you could say, well, that is peculiar. Beware, again, this is OECD data, meaning OECD countries have been investigated, and as such, OECD countries are rich countries, meaning that doesn't necessarily give a good picture of that statement, life expectancy and ratio of doctors, because in other parts of this world it might look completely different. He also said that there is a paradox in the number of graduates and the number of practicing professionals. So again, there is no correlation to be found. Now, the ideas raised then in the two workshops, and they were very different, those two workshops, in terms of sort of, if I may say, the first workshop was a bit of more the macro level discussion, whereas the second workshop was more the micro level, but I think it was a nice mixture of getting a better picture when we talk about workforce challenges. One idea which was raised was better value. Is there a better value for patients with fewer doctors but better teams? So should we just take it as a given that there are fewer health professions and you just need to, let's say, task shift or invent some new profession, invent some new roles? It's a debate which is very prominent in the medical profession, and as most of you know, the medical profession criticizes task shifting a lot, but certainly doesn't criticize the idea of very good teamwork and collaborative practice, which is certainly key. Another idea which was raised is, why shouldn't we start new models of service delivery? We have to have better primary care, more specialized healthcare, meaning that, for example, not for any little problem hospitals admit patients to deal with these problems, but to have better organized primary care so that patients can be treated at that level, not to use very expensive hospital care. And what we should look at is better integrated care, in the meaning to better also link social care to healthcare. Another idea which was raised was, should we count into the workforce also the digital manpower, and how do we do that? Which is something in theory a bit, but it's something we in the long term need to think about. How can we count in the digital aspect in workforce? Solutions which were addressed, or something which we wanted to see and which came up in both workshops was, well, one thing which was raised several times is, of course, you need to keep a profession attractive and to increase attractiveness. And in some parts of the European Union, you certainly need to have better salaries. You need to offer good career opportunities, also in terms of continuous professional development. You need to have a professional profile which is sort of appreciated. And one thing which was very interesting, I think, was countries actually have to advertise jobs. There are many countries in the European Union with shortages and they don't advertise. To give you an example, Austria, well, they might have shortages, but they're very successful, apparently, we were told, that they advertise jobs and get a lot of migrating health professions into the country from southeast. So it's always the movement east to west, south to north, which is, it's globally actually, but also within the European Union. And it's something, so I mentioned Austria. Whereas, so they drag in, if I may say this a little sloppy, they drag in a lot of people from poorer European member states, whereas Italy has also a lot of shortages, but they don't advertise. So you can say, why is that? Well, apparently they don't invest. They're not prepared to invest into that and to create these jobs which are actually necessary. So shortages doesn't equal jobs. In our view, mobility is a short-term solution. Countries must work towards self-sufficiency, which is something which is also promoted by the WHO. And what we need for the future mandate is certainly something that is to continue EU-level workforce policy to also tackle and coordinate these problems I just mentioned. We have one project currently running, my colleague Sharada is dealing with. It's CPME, the expert network on workforce planning, and it's a very valuable tool to get a better picture and to better coordinate what is happening in the European Union. And ultimately, that was raised by you, Nicola. The workforce and patients should seek solutions together. And I think in particular this is very true for the new challenges popping up for the workforce when it gets to digital solutions and what is acceptable in our view and what is not acceptable in our view. So it's something we could look at. That in short, sort of what we discussed, what we propose. And I'm aware that the G20 in Japan took up these challenges in the workforce, discussed it in Japan, and hopefully will draw some conclusions from it. Thank you very much.
Super, thank you very much, Annabel. So again, any further comments from people who joined the session yesterday? Any comments from other healthcare professional communities? No?
You must have some comments.
Stan and then Karen.
Just a remark, probably it's not in one workshop where we can address all challenges, but I think the continuous training of doctors is important, but what is even more important, to have consistency in training models around Europe, which is not always the case, and we end up with different knowledge, and it's not surprising that we end up with different systems at the end. So it's not only about the doctors, it's the healthcare professionals overall. So we can see all varieties of professions, type of organization, of systems, just based on the way they are trained.
Okay, thank you. Karen?
Yeah, I just wanted to add, I was not in your workshop. We had a workshop on health inequalities in May, where the workforce was one of the topics. And it was actually considered one of the negative fallouts. The mobility that is created within Europe is creating the drainage of needed healthcare workforce in countries where it is needed, but where the healthcare system does not have the money to support them. And so I think it's very difficult. Well, one should talk about elements of the problem, but they come back to the same primary problem of insufficient funds for the healthcare.
Yeah.
And of course, you cannot blame people if they have no job to move to a place where they have a job. And as Stanimir said, it's definitely not just about the doctors, it's even much more so for nurses and healthcare allied professionals.
Yeah.
No, this we were fully aware that nurses is a pressing problem, but as mentioned, it was just taken as an example here. But it's true. I mean, one of the conclusions was also it's not about plain numbers really. It's about how do you better organize, and you need to be prepared to invest to tackle these things.
And the panel, any particular comments from the panel? I suspected we'd get some comment from DG Santé. Okay.
So
See representative
just
first.
maybe while I was listening to the challenges raised, I would say I've at least a few ideas on the top of my head how industry can contribute at least to the solutions. So I think the first one is what we can do is contribute the technologies to help address some of the resource inefficiencies and some of the lack of resources. So when we talk, for example, about creating more transparency in the system to understand better where are the resources actually needed, when we talk about connecting better social primary hospital care, I think that's certainly where we would come in as an industry. But I think what's really important also for us that we have the demand side, so the healthcare professionals, the carers, the nurses at the table when we develop these solutions. So that's, at least for us, one of the goals for the next few years, that we institute this collaboration far more systematically.
And that is very, very good news, I think, for both the healthcare professional community and indeed the patient community. Thank you very much, Annika. So our representative from DG Santé, I know it's not directly within your remit, but I would imagine you to have a couple of things to say on the comment around the workforce and continuing some of the work that Santé has driven over the years.
Yes, just thank you very much. So it reminded me some element of my life in the past, when 20 years ago I participated on behalf of Poland in negotiations, accession negotiations, in the area of free movement of workers. So the question was the recognition of diplomas. So we made a huge battle for this, but now when looking at the huge migration from the Central and Eastern Europe, migration of medical staff to Western countries, maybe it was a fault. But there is not only a problem for European Union. We had a round of talks with Chinese. They have also problems with the migration of medical workforce from rural areas to the cities. And we exchanged the ideas how to, keep people working in the deficit areas, in some areas in European Union, in the rural areas of China. So this is the question of attraction and support of activization of the people also, because when the doctors are saying, okay, so instead of consulting the patients, I should spend half of my time on administrative burden. So why? So this is the question of better organization of the service. So they say, I am badly paid, so I cannot treat the way of as I want, so why I should be still active? And my colleagues who look at me say, maybe you should change the profession, simply. And the question is how we can attract people to the medical service, to say there is the possibility of development, there are good salaries, you have the possibility to do something for the people. When we speak about salaries, my colleague who is working now in the clinic in Louvain, quite good, as I know, in Belgium, got the proposal to go to Luxembourg for the triple salary, but to be 25 hours per 7 days on duty and without any possibility for the private time, almost. So this is also the price. So maybe the better organization, maybe the better allowances, let's say, for the doctors, this might be a remedy for the situation.
Thank you. Sinisa, you wanted to come in now.
Well, thanks. I was also a member of, that was Chapter 3, Freedom of Services in the Establishment. And I was also fighting to recognize Croatian doctors as equal doctors in all of Europe. And now, you shouldn't have done that, right? Now it's, you know, I'll just give an example also in Croatia. The Swedish government officially, through the Swedish embassy for students of medicine and nursing, organized free lessons in Swedish since since third year of university on. And they give them good benefits, and they put them in contact with all the agencies for placement in Swedish hospitals. So they already have jobs waiting for them as soon as the government of Croatia finishes investing over 100,000 euros in their free education. Okay? So this is something that I think personally on the level of the European Union should be a system of reparation somehow for this part. On the other hand, I went then to the Swedish embassy and I said, what the hell? What are you doing? Why are you doing this? It's not fair. And he says, life is not fair because Swedish doctors are all moving to Norway for a higher salary. So it's just a part of the big chain of migration through all of Europe. And Brussels is sitting back and pushing papers on from one end of the table to the other end of the table while life is going on. Okay? Thanks.
So, thank you for saying it how it is. This is very refreshing. Martin. Perhaps you take that one, yes. Very briefly, thanks.
Okay. I just wanted to add that, of course, due to the demographic changements, we don't have enough doctors, nurses, everything, even if we advertise jobs all over Europe. In my eyes, there are two solutions. In Germany, we've got sort of requirement planning, so doctors aren't allowed just to work where they want to, because we say you can't all go to Berlin or to the big cities. You've got to work in the rural regions. Because patients over there also need their treatments. This is the one thing, and it's quite a conflict with the freedom of where I want to work as a doctor, and we've got to discuss this in the future, also all over Europe. And the other solution is the digitalization, because if there are video-based examinations and consultations of the doctors, you can also reach the patients in the rural regions. But there are also difficulties with this, and the relationship between doctors and patients is changing if you don't have a personal contact. So this is a big challenge for the future.
Thank you, Martin. Really briefly, because we have a time challenge.
Only mentioning that we have very hospital-centered education for physicians and nurses. We have to change that also.
Into the community. So, Annabel, a couple of reflections on what you've just heard.
Thank you very much. Just a brief comment on the needs test in Germany. Well, it doesn't mean that you can force health professions to establish themselves in the, let's say, rural east. So it doesn't resolve the problem, the needs test. I'm not convinced by that. What you need is really incentives, career opportunities, these kind of things. I fully agree with Mr. Kalamas. And maybe, and what I also wouldn't do, of course, and as CPME, we highly support free movement and the benefits of free movement across Europe. We learned so much, the profession learned so much by getting to know other systems. But maybe we should also pay attention to the fact that mobility is not an end in itself. Just by being mobile, that is cool. Maybe we should better reflect and get some incentives, as mentioned, to keep professions attractive where they actually come from also.
Which is the crux of the problem. Okay, thank you very much, Annabel. So the last session, the economy of well-being, the multiple dimensions of health and well-being and thinking out of the box. This was organised in cooperation with the Finnish EU presidency. The moderator was Stan and the rapporteur, the volunteer rapporteur was František Mudronka. I think, are you in the room? Yes? Lovely.
Well, actually, I'm not František Mudronka because he actually didn't even participate in the workshop.
I'm so sorry. I've got
No
bad
trouble at
information.
all.
Excuse me.
No
Excuse
trouble
me.
at all.
That was a little admin blip. So who are you? Reveal all.
Okay, I'm Roman Odlozilik and I come from the Czech Ministry of Health. Well, my colleague František is also from the Czech Ministry of Health, so maybe that's where the confusion came in.
Yeah, apologies.
Okay, fine. Well, this gives me great pleasure to be here and to tell you about our workshops and about the outcomes that we identified yesterday. Well, the title was The Multiple Dimensions of Health and Well-Being and Thinking Out of the Box. And I can truly say that there are genuinely manifold ideas flowing in the discussion. So I will try and make this a coherent talk about what we figured out. Now, this presentation was created only a few hours ago, so it won't be that fancy with all the pictures. But at the same time, maybe I was like trying and I wanted to prevent you, from the sight of me fiddling here with this thingamajig, which I guess I would have never worked. So, there will be only one slide, but I guess, bear with me and all the information will simply pop out. Now, at the beginning of the workshop, we had this representative of the Finnish presidency to the council who told us about the priorities that they want to simply push forward within their presidency. Now, the core principle that echoed there was the economy of well-being, which should be translated into all policies of national legislations. Now, this is linked to the previous Finnish presidencies to the Council that were also talking about health in all policies, in all walks of life. Now, what echoed very strongly there was that the investment or the costs into health or the health expenses is not really an expense. It's not just a budget expense, but it's truly an investment into the future and into lives. That's why the goal, also one of the goals of the Finnish presidency, is to change the mindset of not only of people but also of politicians, because we need to make them realize that investing that the costs, or healthcare costs, is not only an expense but really an investment into the future. Now, what was quite positive to hear was that there are truly no new competencies required, and we can make all this work within the current framework, within the current legislative framework, because the framework as it is offers possibilities for change, and we simply should make that work, and we should make it work for our advantage. Now, as I've already mentioned, the health and the healthcare aspect should be integrated and translated into all sectors, and that should be the core principle, the driver within for the Finnish presidencies and for the national legislation, and basically for all the stakeholders involved. Now, what was warmly welcomed by the participants of the workshop was the fact that this should be a start of a substantial political debate, because you know that we can be talking about it here, and we all agree that it's an important agenda. It should be a point on all agendas when talking about health. But we do not need to make ourselves believe it is so. We need to make politicians believe that it is so, and we need to make citizens and our co-fellows simply make believe that this is so, that we need to think of health as an investment and of something that simply needs to be thought of whenever you're talking about all walks of life. Now, the trouble came when we tried and formulate the definition of well-being, because we need to realize that there is no unified or uniform or uniformly accepted definition of well-being, because you can have objective definitions of well-being, you can have subjective definitions of well-being, and this is basically it all boils down to how individuals simply perceive well-being. And one thought that that echoed there was that a well-being is when you are secure, that you know that someone or that things will be taken care of, not only like professionally but also in your private life, that you simply know that there is something to fall back on, that there is this feeling of security. Then this also brings the feeling of well-being. Now, naturally, there were like other challenges identified within the workshop, and one of the challenges was how to do away with the distance between the Brussels bubble, as it was called there, and EU citizens and individual, because we need to realize that again, individual citizens or local or regional governments are not really in touch with the Brussels agenda, and that's why it can sound very fancy to be here and talking about the economy of well-being, but if we don't get the local governments or regional governments and the individual people to our side, then this will be quite a futile exercise. That's why we identify the solution should be the communication, a good communication between Brussels to national politicians on the national level, but also the regional level and local level. Because without that, without this communication, we will never be successful. Because basically, our ideas, our thoughts, the thoughts of the economy of well-being, the thoughts that health should be integrated into all walks of life, will never truly hit its square, with individuals. Now, as my colleague Sinisha pointed out in the workshop, this is also the question of how to get the media on your side, because once you are a politician and you start thinking out of the box and you really want to be reformative and you want to bring the health agenda in the discourse, in the political discourse, then it might be a political suicide, because these are steps that basically are not popular, let's face it. And that's why we also need to get the media on our side, to reflect positively on what has been done, on what wants to be done, what is planning to be done, and to have this media backup for the politicians, because without that, again, it will be just a one-round session, and the reforms that could have been done will only last for one period for the life of the politician, which is not really worth it, is it? Now, what is also required, or what we identified as a possible solution, is this bottom-up approach, because once you change the mindset of individuals and make them believe that health is truly an important asset, then you will have them, you will have the citizens simply push the politicians to make more, to achieve more in the healthcare agenda. So that's very important, not only having the media on your side, but also the citizens on your side, and make them believe that it is simply worthwhile. Now, we identified that there is quite a strong civil society within the European Union, and we should definitely make use of it once we have it. Now, also an important tool that can be brought into action and used more is this European semester, which is a beautiful platform to bring this, you know, both viewpoints of economics and healthcare together, you know, to make politicians talk together, to show that once you cooperate within both these fields and not separate in them, then it makes sense and then you can basically achieve more. The Finnish presidency then pointed out that in some areas of the economic well-being, the decisions that will be made will be knowledge-based. You know, sometimes we do not necessarily have all the required data, we do not have the hard data for the change, but we do know that something should be changed. So, you know, some of the changes should be knowledge-based, and that should be the driver for the change. Now, what is also echoed in the workshop was that within the European Union, there have been many projects that have been financed by the European Commission. And these projects focused on good practices or best practices in the healthcare sector, in the, again, you know, various walks of the healthcare sector. And the truth be told, these outcomes or the results of these exercises are not always put to best practice, are not always really disseminated, are not really you know, made use to our advantage. And that's a pity, because you know, once the European Union paid for such projects or collection of, you know, best practices, then we should definitely, again, you know, be able to translate them to everyday life, to show them to politicians and tell them, okay, fine, you know, here you have the evidence that this and that works, and this and that should be that way, because, you know, we already know from that member state, and that, again, you know, could support the idea of the economic well-being. Because, you know, once we don't do that, we will again and again be reinventing the wheel, unfortunately. So this very briefly from me, and if you have any questions, or from the participants, if you want to add anything, please do jump in. Thank you very much.
Thank you. Thank you. So anything from the audience before we move to the sort of final panel discussion in the last half hour of our session? Lynn?
Just to say thank you. I think you've captured very much the tenor of what was said yesterday. And I think from my side, from the patient-citizen point of view, there seemed to be a genuine willingness to take on board all these points that you're saying, which is very refreshing. I think that's perhaps marks a new era, and I hope that we can take this forward together. So thank you.
Stefan?
Good morning, Stefan from Digestive Cancers Europe. Thank you for your nice presentation, and I agree fully with many of the points that you suggest, especially best practices. I think we had a discussion this morning on do we have the data available, and my point is no. I mean, we lack a lot of data, especially with outcomes and application of best practices. So within Europe, and I think first of all we have to be very positive about what has been achieved. I mean, anybody with cancer, the best place to be treated is Europe, by any stretch of the imagination. What we also see is that the highest increase in improvement of overall survival is in Slovenia and Lithuania. And Slovenia is as good almost as the Netherlands today, and Lithuania caught up with the United Kingdom. So significant increases have been made over the past 20 years in some countries. Why? Very often because they start from a different perspective and they have less rigid organization of the healthcare system. So they become more innovative in how to deal with the traditional roles and responsibilities between doctor, GP, oncologist, hospital, the way things are organized. So I think a lot can be learned also from the creative ways in which some of these countries achieved results with less input and less money invested. We also see within the richest countries big disparities between the outcomes in hospitals. So in Sweden, if you have colorectal cancer, you have 20 times more chance of death in a smaller hospital than in Stockholm. And I think this is the same in the Netherlands for with the data. It's the same in Belgium where we have the data. So we have to look what are these hospitals doing that generates that outcome and stop the small hospitals from doing what we're doing because, as you mentioned earlier, patients are channeled to places where they get killed instead of
So
saved.
just to be a little provocative, Stefan, what would be the one thing that you would be looking for in the next mandate with that sort of backdrop of your experience from the cancer sphere?
I think European Union should have a much stronger outcomes database by disease area.
Okay.
And specify what happens by disease, because I don't think you have policies that can cater for everything. The only solution is to do it by disease area.
Okay, thank you. Very clear. Annabel.
Just very briefly, one question. Did you discuss a little more how to get the media on your side? Because from experience, I mean, this is one of the key problems that Europe doesn't have the public, so to say. I mean, it's a very, I don't know how it's in your home country, but many issues are not properly explained and citizens are just, it's too complex. So did you discuss this a little more?
Well, not really in much detail, but what I believe should be the solution would be, you know, really like talking to the media, having these press conferences, telling them what it's all about, making them see what the politicians should be seeing, making them see what this is all about. You know, not letting them simply covering the agenda by themselves without the really needed information, but giving them the information, feeding them the information, like really, you know, pushing it down their throats, because, you know, without that, they would never be of help.
Okay, good. Thank you very much. Thank you for your input, and I apologize.
May
once
only,
again.
sorry,
Yes,
interrupt.
please.
One of the definitions of health is that it is physical, mental, and social well-being. So the title, The Multiple Dimensions of Health and Well-being, might be sometimes confusing. So let's speak rather about well-being, that it is health. And I would like to congratulate Finnish presidency of this excellent topic to discuss, because we, as the Commission, cooperate with OECD a lot on economy of prevention, which is directly linked to the well-being or the health. So this is very good trace. And ad vocem, what Stefan said, so Europe is the best in treating cancer. What is the best region for prevention of cancer? Is it also Europe? I have some doubts, because as Okinawa paradox is showing, before 72, Okinawa inhabitants didn't know any cancer, cardiovascular disease, or any generally NCD. After taking protectorate over Okinawa by United States and influence of so-called Western lifestyle, they started to change their approach to the life. They changed the diet, and the NCD started to appear. So maybe we should take into account this element first of all. Thank you.
Thank you very much. And while you have the floor, because we're really coming to the sort of crescendo of our meeting, perhaps you could give us a little bit more insight. We discussed earlier from your particular lens, because you have responsibilities for social determinants, the international agenda within DG Santé. Where do you see things moving forward? What are the big, bold things you'd like to have in place from your perspective as a Commission official in the next period moving forward?
Thank you. At the very beginning, some comments to, brief comments to the previous presentations on prevention. So I am dealing mainly with only with the behavioral health determinants, so nutrition, physical activity, addictions. So we have also, of course, social determinants and environmental determinants, just to mention two big groups. Can we influence them somehow? Environmental determinants, yes, with appropriate legislation and money. Social determinants, maybe mainly with money. Sorry for shorting a lot. Behavioral determinants, probably also we can influence somehow. But to those who are practicing doctors, when you have the patient is looking for what? Prescriptions of some drugs, the ordinance to the specialist, sometimes for the good advice. But how many times they are looking for the good advice, and when they are advised to stop smoking, to stop drinking too much alcohol, or stop drinking alcohol at all, change diet, change lifestyle, to move better, to move more, what they will answer? It's too much for them. Mm-hmm. So they expect usually miracles from the doctors. And this is the problem. Yeah. The European Commission started this year the project on lifestyle medicine, just to have the better picture how the doctors are prepared to advise patients or the people generally, because it starts with the school, what to do to be more better, to be more healthy, or to be healthy generally. So this is one remark.
Can I just come back here, because I think we've already established that we should avoid the blame and shame. I think this is a lot around patient empowerment and a genuine dialogue between patients and their trusted healthcare professionals. And I'd just like to you've talked about several different determinants. Yes. You haven't mentioned the commercial determinants of health, which Fiona raised in her presentation. What's your thought on that?
Commercial determinants.
That's the one.
Okay, this is interesting subject to discuss. Do I understand correctly that you mean as commercial determinant of what we meet on the market, let's say?
I think Fiona can probably say a couple of words in what she meant in the prevention piece.
We were referring to the fact that there are economic actors who are actively trying to discourage or prevent us doing the right thing, and they might be, you know, obviously big tobacco is one, big fuel, big energy with its polluting policies is another one. I mean, there are lots of them, but yes. and also just to refer to the fact that a very striking comment that I heard, I was watching the head of the Joint Research Centre give a very good talk in Tokyo last year. And he, in passing, just said, governments do not have any power these days. Power is all in the hands of multinational companies. And that wasn't even the topic of his speech. That was just a throwaway comment that he made in passing from one slide to another, talking about, you know, the interface between research and the public. So that's what I mean, the influence of those actors on our ability to act.
Yes. And if you could respond very briefly, because I'd like to hear from the other panelists.
If we take into account that we spend only 3% of our healthcare budget on prevention, and international companies spend 100 times more on marketing than healthcare systems on making people aware what might help them, so we lose the battle at the very beginning. So what we can say, it's not true that all the power is in the hands of the international companies. The governments are ruling the game, and as the European Commission, we support only member states in EU, but the member states can do what they see is feasible and effective in the member states. Let's take into account, for example, Lithuania and the problem with the alcohol consumption. So we could only advise Lithuania what is done in the other member states, showing the best practices, and they changed the legislation. They changed the legislation as regards the taxation, as regards the access to alcohol, as regards the licensing. So these are the elements which should be taken into account, not only as regards the alcohol, all addictions. So
Look, I'm afraid I'm going to have to cut off. I think your point is very well made, and because of the timing, I'd like us to move to the next panelist, and hopefully you'll be staying over lunch so people who are interested can have a further conversation with you about your specific role. I'd like to move now to Annika from COCIR, and we've heard quite a lot in the community about the idea of a health partnership, moving on beyond the Innovative Medicines Initiative, to actually look at other forms of innovation, not just medtech or digital innovation, but actually social and systems innovation. Can you say in a very, very brief way what your thoughts are about that and where COCIR is on this kind of future initiative?
Yeah, of course. And I'm now not only speaking for COCIR, but actually the entire industry consortium that is currently discussing that initiative. So to give a background for those who are not aware, the European Union is currently discussing the next funding program for research and innovation. So we're talking about several billions of money that need to be allocated to research in all different areas of society and economy. We have heard, I think, a lot today about the very many challenges that healthcare and healthcare systems face. What we have also done is we analyzed, are we doing enough in research, development and innovation to actually support solutions for that? And our answer was no, we are not. And there are actually several reasons for that. So the first one is that in Europe at the moment, we are not good enough at really translating the, excellent research that is being done in our university hospitals, in our universities, in our technical universities, in our RTOs, into actual products and services that the systems want. And the second one is, as an industry also, we're talking a lot about the need for more integration in the systems, integration of workflows, integration of different parts of the system. But actually, we also must make an effort to integrate between each other. Because at the moment, what is going on is you have the pharmaceutical sector doing the R&D with their own constituencies. You have our own members, medtech and digital health companies doing their own R&D, and we are missing out on just a lot of new ideas and a lot of innovation that could come out of collaboration. So what we have done actually for the past year is we said, okay, we need to do this together. We have to be more ambitious than we have been for essentially the past 3 decades. And that's why we have put on the table a very ambitious proposal towards the European Commission for a public-private partnership on research and innovation in the healthcare area under Horizon Europe, that really is trying to cover the entire continuum of care. So prevention must be included. That certainly has been missing in the past funding programs, especially also in industry collaboration. We must definitely be better at getting the supply and the demand side together. So what we're currently discussing is how we really get the member states, the payers, the public authorities, healthcare professionals, citizens, patients, carers at the table, co-creating this partnership and implementing it later on. I think what we have also said is that it will require a lot of work from our side. So I have now been in a lot of meetings where our members, really the researchers on the ground, had discussions on actually how do we address cancer and how can we, for example, personalize treatment along the entire continuum of care.
Thank you.
So and I have been very surprised of how many ideas are coming out of these discussions. So I think it's a very, it's a very positive, we're very excited about this initiative.
Sure, and I guess from the civil society side, it is about how that public piece of that public-private partnership actually manifests itself both at governance level in terms of strategic priority, but also how things move forward on the projects themselves and the voice of patients and citizens and other stakeholders. I'd like to move on now and apologise. We've had a very rich discussion, so timing is not on my side, mea culpa. But I'd like to perhaps come back to Marine on the core question of the Sustainable Development Goals. That has been the red thread through this conference, one way or another. You talked a little bit about the role of SDG Watch in actually making sure that we're all accountable in terms of driving this agenda forward and achieving where we need to be in 2030. What do you think are really the critical factors from your perspective? And very brief, I'm afraid, a couple of minutes.
Yes, I'll try. So it's true that I'm here on behalf of SDG Watch, but I also work at a French NGO that is called Global Health Advocates. And my input to this discussion is more related on the work that we do on advocating for the implementation of health in all policies, which fits really well with one of the workshops that the results of which were just presented. So I like to say, what is it as a civil society group of NGOs from different fields? What is it that we see that needs to be done for the implementation of health in all policies? Just to mention that we have recently published the Civil Society Guide for Healthy Europe for the new members of the European Parliament. That is back at the room if you want to have a look at it. And it's an ad hoc initiative that brings together, as I said, civil society organizations, not only from health, but also from environment, agriculture, and food sectors, to come up with this, the proposal from the side of public interest group, what the EU needs to do to implement this health in all policy approach. And our starting point is that health is a basic human right, health is an issue of social justice, and that is why it should be at the core, people and their health should be at the core of EU policies and not only profits. So this is where we come from in putting down our recommendations. Like briefly, what are the recommendations? It's nothing innovative. It resonates some of the recommendations that different civil society or industry groups are proposing for the prioritization of health. The main ones is, again, like to echo what Fiona and some other people were saying, that what we need for the implementation of health policies and prioritization of health is political will from the side of the EU. So how it can be translated? First of all, to have strong governance to ensure the implementation of health in all policies, the high official from the Commission, Vice President for Sustainability Wellbeing, that will ensure the implementation of health in all policies across the different policy areas. Strong Health Commission, which will be staffed and financed accordingly with a specific sector that will look into coordination of work of different DGs to make sure indeed that health is taken into account in different policy initiatives. And finally, for the governance, we think it's important to have civil society mechanism attached to health DG or Vice President of Wellbeing if we are successful in having that, which will ensure the accountability and transparency and inclusion of civil society communities in the implementation of health in all policies. Second one, sorry, and I finish, is the impact assessment of different health policies, which again resonates that the ask that that's included in the health pact, because if there are many issues. When we know that health is, it was already mentioned that many determinants of health and health inequality have social, economic, commercial, societal determinants. So if we want to ensure that health of citizens and people is protected, we have to make sure that any policy areas and policy initiatives that EU undertakes do not impact negatively on health. So we think this can be one concrete mechanism to put in place to ensure that EU meets its commitment in terms of ensuring high level of protection of human health. Sorry for being quick. I tried to.
No. But I think this is echoing very much some of the thinking and reflection that's happened in other initiatives that we've been working on collectively over the last couple of years. All policies for a healthy Europe. I think some of the recommendations or aims are very similar. Where we're looking to in terms of the health coalition that came out of the health summit last year, the EU for Health, which was the EPHA, EPF initiative, really looking at the threat to health and where we want to go in terms of better and more health collaboration. Many of those recommendations that you've talked about echo in that environment. And it's really positive that everybody is moving in allegiance in the same direction. So it's fantastic to be able to collaborate with you. Martin, you're from a member state, Germany, and clearly your environment is discussing on an ongoing basis what's the added value of EU cooperation, what is the stuff that needs to be dealt with in a national context. You're coming at it through the lens of an umbrella organisation, a very powerful patient organisations. Again, very briefly, and we'll talk more over lunch, what are the big things for you?
Okay, difficult to say it in a few words.
Elevator pitch.
But thinking of the role of the EU in health politics, we always have the problem that the development of the social systems is in the competence of the national governments, and this is determining the structures of the healthcare systems in the different countries and the access, the reimbursement of the treatment. So this is important, but I want to point out that the role of the EU is important as well. Looking at the assessments of drugs and medical products, this is very obvious. And in this field already we get important transparency also for patients, which drugs are better than others. And in my eyes, the key word for the further development of the EU health politics should be to develop transparency all over the systems, because we've got also structures that have to be known better by patients, which hospitals have which equipment and which results concerning quality, which outcome, and this is for patients, this is very intransparent at the moment. And I just want to give one example because we don't have much time. In Germany we had a law that the hospitals had to give information concerning the quality of their services, and the first step was that they just gave narrative information which wasn't objective, it was close to advertisement. And then next step was they had to give objective information about the quality of their services. But then they just published it in the internet and we couldn't use it because we hadn't the data format to put it in search engines in the internet, and we had to go to court, and luckily there is a Freedom of Information Act in Germany, so they were forced to give it in a data format to use it in search engines. And now we've got a search engine where patients can choose the hospital about their individual needs, but we have to do it ourselves as a patient organization, and this is very expensive and it's a big task. And the next step will be that the government has to finance it. And in my eyes, the vision should be that one day on the European level, every patient will be able to have these search engines in their countries, not only for hospitals, but for every service and every treatment, every drug and every medical product. So I think there's a big challenge for the EU to improve transparency in the healthcare systems.
This is a really interesting dimension, something new, something fresh, the transparency piece in relation to patients and citizens accessing quality of care. And of course, we have, in a way, the legal base with the Directive on Patients' Rights on Cross-Border Healthcare, because of one of the indirect benefits of the directive. I mean, there are lots and lots of challenges, but one of the indirect aspirations, I think, was to actually raise the lowest common denominator across Europe with regard to quality of care. Really great points, Martin. Päivi, we've talked a lot about the work of the Finnish EU presidency, and I think it's been really warmly welcomed. We've had a whole session on it. Rather than focus on what you're doing, in the next few months. Why don't we look ahead, project ourselves in a few years? What legacy would you like to have personally and as the Finnish presidency in a few years' time, looking back to think about this 6 months, this critical 6 months? What would be the couple of things that you would be proud of?
Thank you, and I would like to thank you for excellent discussion and very comprehensive discussion around the economic of well-being. There is already a lot we can then bring back home from this discussion, and I really would like to encourage you to continue this then, because now it's the time then to try to influence on the dialogue and the outcome. So I would really want to encourage you to then help us then, the Finnish government then, to really be able to have a very strong influence then on the future and to make this economy of well-being fly as well as we have succeeded with health and all policies. But not only in the health field, but I would like to see that the economy of well-being and the understanding of the impact of health and all these dimensions we have discussed here already today, that what kind of impact they have on sustainable economy, but also security of societies and sustainability of societies. So that would be then the best outcome that we can get, that this is a common policy, not a certain sector policy.
Great. That cross-sectoriality again coming to the fore. Thank you very much, Pavi. Last but not least, Sinisa, can you just again, from the Croatian perspective, you will be having a presidency in the not too distant future. Can you share a little bit some of the aspirations and the red thread coming from some of the, let's say, diamonds that we've talked about in the context of the Finnish presidency?
Thanks. So we look forward very much to seeing what's happening during the Finnish presidency, and I hope very much that we will have a continuation and build up of everything that's set up, especially in the area of well-being. The 3 areas that Croatia has been reporting to Brussels as focus areas for the presidency in health are transplantation medicine, healthy aging, which is well-being, and also they were talking about patient safety, but they're looking more into oncology now, especially for the EBSCO meeting in June 12th of 2020. So these are the focus areas of Croatia. Of course, transplantation medicine is a showcase because Croatia, similar to our football team, it's fighting globally for first place with Spain. So we're constantly, a little bit up above, a little bit below Spain. Spain is moving a little faster now in the last half year, 1 year, and this is something that it proves that a small country can have very big results also in healthcare. I keep on telling the Ministry of Health, sure, use the model that you have for transplantation, put it to cardiovascular disease, stroke medicine, cancer care, etc. So if you have the proof of concept, do a mini twinning project in your own country. You don't have to look abroad to have best case or best practices when you have it in your own country already.
Sure. And this comes back to your idea of good neighbours and learning.
Yeah, exactly.
Internally within a country, but also obviously
I for instance, I went to Bulgaria to assist with the transplantation program, and we have excellent staff in the transplantation team at the Ministry of Health who is always willing to expand their knowledge base to other countries. So you're always welcome to this.
Excellent.
So just as a final message, since we're here with the Patient Access Partnership, personally always was a big fan of NGOs, patient advocacy groups, patient alliances, and I always considered patient advocacy groups an integral part of the healthcare system. Okay, as you have a doctor, you have a nurse, you have a patient advocacy group. This is a normal, integral part of the healthcare system. A lot of times I get the sense that Ministry of Health is on Mount Olymp or in a bubble or however you want to call it, and has a very thick skin to patient advocacy groups. Okay, so this is something that I also want the Finnish presidency and Brussels to break down these bubbles and all governments. And if my last message, if you feel the thick skin if you feel that there's no movement forward, if you feel that there's no political will for change and betterment of the healthcare system, please lose your political correctness. Put on a yellow vest, because if yellow vests could have been used to change the price of gasoline in France, then I think we can help to keep people alive instead of dead. Thank you.
Great. Do you want to join the patient advocate movement? Just asking.
I am.
Actually,
I am. Yeah,
you are. But also, I mean, with
So
regard
the unified message would be a very good thing. If everyone arguments something different, it doesn't have as strong impact as you have a unified voice.
Absolutely, absolutely. And I think this has been something that's actually come through the last day and a half in a really strong way. Just coming back to the previous comment in relation to the integral role of patients, just to let you know, there will be a congress in November that will be doing exactly what you've described so eloquently, looking at the patient's role, actually helping to design systems, helping to design services, and really working out, and people want to do it, but really how to do that and having the resources and tools and moving away from isolated pearls into something much more systematic. But I mean, you can find out more about that Congress by talking to Usman and other EPF colleagues. DG Santé, the last word.
Thank you. So I would like to draw your attention to the fact that a new European Commission will be formed hopefully in November. And it will decide about the future of health in Europe for the next few years. And I hope that it will be the continuation what we started in this term, so a big focus on prevention and disease prevention and health promotion. Of course, there are some areas which still to be continued, but I would like to draw attention to the multi-annual financial framework, which offers a lot of financial opportunities, and that there is the spatial health strand in the European Social Fund Plus, which is quite big and will be able to finance a lot of projects. Two more information. Commission started so-called missions. One of them is mission on cancer. So we will look for the new research and innovation ideas in prevention and treatment of cancer. So this might be a very interesting area for a number of you. And I would like to call everybody who is sitting in this room to check the website of EU Health Policy Platform. So those who are registered know what I am speaking about. Those who are not registered, this is a forum for exchange of information where there are a number of thematic networks, and this might be interesting for a number of you, even from distant areas, to participate in the discussion on interesting subjects. Thank you.
Thank you very much for that contribution from Santé and the Commission. It's fantastic to hear the commitment, the ongoing commitment here there. Also, Member State representatives, it's been so precious to have your insight and your energy and really your sort of radicalism as well in some ways in terms of moving things forward. That's really refreshing. And not forgetting the European Parliament. I think we got some very, very clear messages from Andrei Kovačov yesterday, who was instrumental in actually setting up and running the interest group in the European Parliament on equity of access to healthcare in the last mandate, alongside other passionate colleagues from other groupings, other political groups and so on. And the impact of that was really, really strong. We really managed to get quite a lot of business done. Yesterday, again, coming to this issue of allegiances and alliances, I talked to my colleague Sultan from the European Public Health Alliance, and he made an interesting remark. He said, 5 years ago, we were in a different ball game. Things have really changed. Now the health stakeholder community are more willing to work together, partly because the situation did become quite dramatic, and the crisis of what is the future of health collaboration was very tangibly there. So I think, I mean, it's not all roses in the garden either, but that fundamental layer of trust in terms of moving forward together is definitely there, and that's a very strong basis for our work together in the future. I'd now like to pass the floor to Stanimir to talk a little bit about the Health Pact that we've been working together, co-creating. And I think this is very much the esprit of what we've been discussing over the last day and a half, and in fact, what the Patient Access Partnership is all about. So Stan, the floor is yours. And we'll thank our panellists in your final speech, I'm sure.
Thank you. Thank you very much, Nicola. Actually, this is the moment when I think this conference shouldn't stop. Actually, the conference is stopping, but we have to start rolling out these messages and these lessons, I would say, that we learned here, because I personally learned lots of lessons, and I will try to change the way I think and I work from the sphere where I come and the place where I come. But I think that at the end, this change should start from each of us in ourselves. I was listening careful to all outcomes of the workshops and all the ideas. All are fantastic. But somehow we stay in our silos. Somehow we continue to put the things in from our own point of view, which is great, and this is why PACT exists, to bring different stakeholders together and make them to try to find the synergies, but also try to find the new things, and that they can bring together to new level of discussion, let's say. But still, I think all of us are thinking in their own silos, and this is probably where we have to start with. We cannot expect the others to understand our silos, since it's difficult for us as healthcare sector to have common understanding on some things. So we cannot expect the finance ministers and the economic ministers and the councils to really understand our messages, since we are not aligned in messaging. And I fully agree that we have to stick to simple messages, but messages that are understandable for the others. And we shouldn't stay within our sector, but we should try to collaborate and go to the other sectors and talk to their language rather than waiting them to understand our language. So with that in mind, I think that the overall feeling for myself after this conference is that thinking in silos, planning in silos, acting in silos, even funding in silos is not the right thing to do. And each revolution has been led by 10% think different and alike proportion of people and leaders. And I think many of those leaders are here in the room. And thinking differently is not always a bad thing. And I think we are coming to this point. We learned to be together. We learned that getting together is actually much stronger and better than working alone. Now it's time that we find out the other lies and we bring the health debate to another level. That's why I think it's extremely important new way of messaging and positioning healthcare with the economy of well-being. It's just one way that we can use to put our message ahead. But the years to come, the next 10 years, are crucial for us. There is a moment of urgency right now on how the new Commission and the new Parliament are going to be set. And that's clear. But this moment will expire in November. It's much more important not only how we will structure the institutions, but exactly what mandate we are going to give them to drive in their daily agenda. And I think what we did in the last 2 days is clarifying a clear mandate in terms of health and healthcare from the perspective of all stakeholders. This mandate is drafted in a document that we call the future of health, the Health Pact, actually. We played a bit with the words PACT, because we started calling the Patient Access Partnership PACT, because at those times it was PACT between key stakeholders that we will start to work together. And obviously, this pact has led us to new ideas and new ways to bring our ideas and our problems and issues and to transform them into opportunities and to make the case to others visible and obvious as well. So having a pact on the future between us and other sectors that are not directly health sectors, but very much think alike and friends, I would say, rather than enemies. And this is the other thing that thinking in silos is creating. We cannot put the blame on the others that they don't understand us. We cannot simply say, these are the good industries and these are the bad industries. We have to somehow start really understanding what drives the industry, what drives the member states and their economies, if we want to have our messaging properly understood by them and proper actions to be taken by them. So again, paving the future is actually transforming ourselves and the way we are thinking and really driving a future that's much more collaborative than separative, that's much more supportive and understanding rather than dividing us. And that's trying to find the bridges rather to build the walls between us. And I think the economy of well-being is a great example of how we can build bridges rather than building walls, and would strongly encourage all of you to take a look into this document because it will stay open for comments for the next couple of weeks. And hopefully afterwards this document would be widely used by all of us here in the room, and this would be our agreement, our pact, our contract on what we commit. Because here I see lots of words, the European Commission should do that, and the member states should do that, the industry should do. We all have our responsibility in this process. And having this responsibility, please take the responsibility to look at the document, make contribution, and use it afterwards. Because I think we have to plan our future with actions where we are part not only of the planning, not only of the say, not only of the identifying the need, but in the implementation as well, and sharing the responsibility as well. And this is where I see the future of health. Shared responsibility, shared understanding. And thank you very much for your shared time for the last days and your shared knowledge, because nothing of that wouldn't happen without you, without the steering committee of PACT, without the help of different organizations who have been hardly working on setting this conference in the way you saw it. So thank you for the European Public Health Alliance, to CPME, to the industry associations that are a brilliant example of how cooperation and bridges can work, because when we started PACT, they were not even thinking that they can talk to each other, some of them. And also the healthcare community was a bit not, let's say, carefully stepping into these areas of industries, cooperation. So thank you very much for everyone contributing to that, and thank you for you being here and giving really your knowledge and commitment. Thank you to the institutions who have been also part, even not kind of formalized part of setting the agenda and giving their thinking also of their challenges and their perspective on that. I think PACT at the end found a way to involve different stakeholders without really thinking in the silos and making them necessary members or formalized things. So we have to keep this spirit. And with this spirit in mind, I would also like to thank the sponsors of this conference. Even though, I mean, it was a huge challenge even for them to provide funding, because, as you may know, PACT is actually not allowed to receive direct funding from industry. So they had to go through one of the PACT partners, which is National Patients Organization. Even this shows the complexity of our sphere, and that we have to find ways to change internally, to change the way that we think. So, and these challenges should be turned into opportunities, I believe. Last but not least, I would like to thank two incredible women, 3 actually, who were really drivers behind the setting of this conference. And the first place and the first prize really goes to Lina, sitting behind, because she's really the person behind. Thank you very much, Lina. Thank you for your help for doing that. And we are really sorry that soon you are going to find, actually, to be involved, not to be involved so much in PACT for various reasons, but our doors are always open, and we all will remember what you did. The other 2 women are Nicola Bedlington and Susanna Paukonen, other 2 bright minds and drivers behind PACT on behalf of the European Patients Forum. Thank you very much. You have been fantastic on that. And last but not least, thank you very much for the great political recognition from the Finnish presidency. Your support was extremely important for us, the stakeholders, for reassuring us that there are hopefully more than 10% think alike within the member states that would drive the change together with us. So with this 10% think alike, I'm very empowered after the last 2 days, because I believe this percentage is actually much higher. It's closer to the 90%. And I'm very much empowered for the next period, and empowered with ideas on how we drive this change in the next weeks, months, and years, with the long-term thinking and the short-term winnings that we need to have in order to sustain in time. So I will put a full stop here with my endless sentence. Hopefully I didn't bother you with that. Is there any suggestion or comments on the way forward with this document, the Health Pact? Something that's burning you, or something that we are missing? Because I have several of those, but it will go via email. Or suggestion how we should proceed with this document in order to make it really live and useful for your work in your organizations, and as we saw, your work with other organizations that are probably not in this room even. Reflections? Yes, please.
It's not mentioned a lot. It's privacy. Thank you. It's the privacy. So it was mentioned yesterday afternoon. So here in Belgium, when you go to hospital A or to hospital B, it could be that you have 2 databases with medical information. So referring to GDPR last year from Europe, isn't there a possibility for Croatia to set a point to assure me that my medical data is clear, nobody can read it, and there is no abuse, and it's right? So there are three points that for me are very important, but I see a lot of problems. So it's especially in, because I think the GDPR law is very strong. There is one article for medical data. So couldn't you create something that you, I think, a norm, now here in Belgium I have 3 passwords, I have 3 databases where I can look, so it's not coherent for me. You see what I mean?
Agree. I think this is already next phase of the Health Pact implementation phase. So feel free actually to use the texts here, because I know there is text on safety of data. So we would strongly encourage you actually to take on that and develop it further. And this is a good example on how we can use it as a document in our daily life, as agreement between us, because this is the unique thing. We are not only in one room now, but we are agreeing on some common agenda and some common topics at the end. And there's no doubt that everything mentioned here matters for us, and we have to drive it forward. Any other reflections or comments? If no, I would assume that we are all happy with the outcome of the conference, and it's really a pleasure to close the conference and to open the action season, especially in the policy field now, in setting commission committees, etc., and agendas, and afterwards implementing them. Thank you very much, and also to the panelists, and see you soon, hopefully in different format or same format or even wider format. Thank you.